Okay, well, welcome everyone. At the beginning of this course, we started talking about the demographics of the United States population and the health disparities within those populations. So I have invited, who has graciously accepted my offer to be here today to talk to us a little bit about health disparities within some of those populations, especially in populations who do have health insurance and those populations that do not. Because since we're starting to talk about the social determinants of health and how they contribute to health disparities, Barbara, who is the executive director of the Free Medical and Dental Clinic here in Iowa City, she's just going to talk to us a little bit about the clinic and some of the disparities that she is seeing within their population as well. So welcome, Barbara, and thank you very much for being here today. So tell us a little bit more about the free clinic here in Iowa City.
Well, first of all, Gail, thank you so much for asking me to be a part of your class. I always like to share information about the Iowa City Free Clinic. It's an incredible organization in our community that many people know about, but we continue to want more people to know about it because the need is so great for our services. The Free Clinic was started in 1971. It is one of the longest running free clinics in the United States. There are about 1,600 clinics in the United States. And again, our clinic is one of the longest running ones. Mm-hmm. The clinic was started by a group of people in the community. Some were physicians, there were some medical students and community members who all believed that access to affordable health care was too expensive for too many people. Mm-hmm. When they started the clinic, it was set up in what is now the Pedestrian Mall, and they rented a room in one of the buildings there. Every clinic had to be set up and then taken down. They held about a clinic a week when it started. Within the first year, the clinic moved to a location on North Dubuque Street called the Wesley Foundation. It's the Student Methodist Center. And the clinic rented space in the basement there from 1972 until 2006, at which time we moved to our current and permanent home at 2440 Towncrest Drive. The clinic is currently governed by a board of directors and employs 4 full-time staff, 2 half-time staff, and between 8 and 10 very part-time staff. We work with an amazing group of volunteers who allow us to do this work. As a small staff, we certainly could not do it on our own. We currently have about 250 volunteers from a wide range of disciplines, including physicians and dentists, nurse practitioners, interpreters, pharmacists, and lab technicians. And if any of your students are interested in learning more about how to become a volunteer at our clinic, I welcome them to visit our website, which is freemedicalclinic.org. There's a place on the site where they can sign up, fill out an application to be a volunteer, and someone at the clinic will get back to them.
Great.
The Free Clinic, as you can imagine, has been through a lot of changes in its 49 years of operation, but the mission has remained the same, and the need of our services remains very, very high. The clinic's mission is to provide quality, comprehensive healthcare services for the uninsured and underinsured in Johnson County and surrounding areas. The clinic exists today because throughout the years, the staff, the volunteers, and all supporters have all agreed that access to affordable health care is a basic human necessity. The Free Clinic provides that access to the uninsured in our community. It gives the uninsured an alternative to the high cost and sometimes misuse of area emergency rooms. Many of our patients have told us that if the clinic wasn't in Iowa City, they would delay needed care as long as possible until they were very sick. And then they would very possibly end up in the emergency rooms, which, as you are aware, is the most expensive place to receive care. Our budget for this year is $640,000, and we rely very heavily on local funding support, in particular grant funding through the United Way of Johnson and Washington counties and Johnson County. We also receive local funding from the cities of Iowa City, Coralville, and North Liberty. We receive funding support through local businesses, local churches, and area service groups. The remaining budgetary needs comes through grants, private donations, and fundraising. Now, obviously, funding support is integral to our operations, but our in-kind partnerships throughout the community also are as equally important to the range of services we're able to provide our patients. Through partnerships with Mercy Hospital, UIHC, Steinler Orthopedic Clinic, and the Iowa Department of Public Health, our patients receive over $1.5 million every year of labs, medications, radiology procedures, and medical supplies. In addition, volunteers donate over 6,000 hours of service every year. And it's because of these in-kind partnerships that we are able to provide our patients with over $5 worth of care for every $1 we receive. Today at our clinic, we have 6 medical exam rooms. We have 2 dental operatories. We have an in-house laboratory, and we have an in-house medication dispensary. These are all on the main level. We also have an 2 administrative offices and a staffing office on the main level. We have a lower level, which today we are using for telehealth due to the pandemic. We are also using it for diabetic education for our patients and for storage. I'm going to share with you some information about our services. Please keep in mind that these are the services we offered pre-pandemic. We hope to resume this level of care as soon as possible. But like all medical practices, our service delivery changed during the pandemic. However, pre-pandemic, we held 6 medical clinics per week where patients received care for acute and chronic health conditions. 4 of the 6 weekly clinics were designated for patients with chronic diseases. We also provide on-site specialty care clinics regularly throughout the year, including dermatology, ophthalmology, physical therapy, gynecology, orthopedics, rheumatology, and prenatal and postpartum care. This coming year, we are working with volunteers, and we're starting to, we hope to soon be able to start offering a geriatric specialty care clinic. Through a partnership with Johnson County Public Health, we are able to provide patients with HIV counseling and testing. Radiology procedures are available through Mercy Hospital and Steinler Orthopedic Clinic, including orthopedic x-rays, mammography, and ultrasounds. Depending on volunteer availability, we hold between 2 and 5 weekly dental clinics. Dental clinics are held on Monday and Thursday evenings, where patients receive exams, treatment plans, fillings, limited extractions, referrals for more complicated procedures, and hygiene. We also hold a weekly pediatric dental clinic through a partnership with a Healthy Kids school-based clinics, and we offer weekly hygiene clinics. Through our case management program, patients with chronic diseases, in particular diabetes and hypertension, receive continuity of care throughout the year, including an initial treatment plan, quarterly visits, other visits as needed to see specialists. They receive medications and immunizations, radiology procedures as needed. And we provide our patients with vouchers if needed to purchase eyeglasses and to help with the cost of medications hearing aids, and medical supplies. Finally, the clinic serves as a gateway to health insurance coverage. Since the implementation of the Affordable Care Act, we have worked with Johnson County Public Health to have a certified application counselor on site to help our patients get enrolled if they qualify and to teach them more about available options that might be available to them. Since the COVID-19 pandemic, we have been challenged in many ways as a medical practice. We made the decision at the end of March to significantly cut back the number of volunteers helping us, at least temporarily, because we wanted to limit the number of individuals coming into the clinic. We are working with some volunteers, primarily healthcare providers and a few interpreters. But as you can imagine, not using volunteers has really affected the number of clinics we can hold. We are currently holding smaller clinics throughout the week, anywhere between 2 and 4. Mainly, these are being staffed by our medical director, our part-time staff physician, and nurse practitioner, who we work with through grant funding to hold nurse practitioner clinics. One of the positive outcomes of the pandemic is that we have added telehealth to our practice, and this has proven to be very successful. We are providing telehealth services for patients both on our main level and on our lower level, and it has really increased our ability to safely continue to provide care to patients despite the pandemic. The clinic serves as a medical home for the majority of our patients. We serve a very diverse, very low income, very vulnerable population. Over 60% of our patients today are diagnosed with at least one chronic disease. Today, because of the complexity of problems that our patients are presenting with, physicians and nurse practitioners primarily monitor and manage their care. We do use volunteer medical students who volunteer during our evening acute care clinics, and they are supervised during these clinics by volunteer physicians. This is very different from when the free clinics started. When the free clinics started in the 70s, we primarily saw patients with acute problems, and medical students played a more active role as examiners. But throughout the years, as more and more patients with chronic diseases have come to the clinic for care, we've changed our treatment model. The majority of people who remain uninsured in the United States are in low-income households. In addition, people of color are at higher risk of being uninsured than non-Hispanic whites. These are the populations served at the free clinic. Today, clinic users include people who cannot find an affordable insurance plan, even with subsidies. We see people who don't qualify for ACA plans, and we serve people who are underinsured, who have insurance, but it covers a limited number of services. We serve many low-income low-income immigrants who have not resided in the United States for 5 years, and as a result, don't qualify for federal assistance programs. We also serve many refugees who may, when they arrive in the United States, receive 8 months of Medicaid, but they then are also on their own until they hit the 5-year mark. We serve people who are between insurance coverage due to job transitions or relocations. We serve people who are in the process of getting enrolled. We serve people who simply can't navigate the system, can't navigate the complexities. I mentioned we serve people who are uninsured, people who, for reasons of affordability, may choose an insurance plan with a lower premium. The plan turns out to have higher out-of-pocket costs, and they find they can't continue to pay. This is particularly true for patients with chronic diseases who need regularly scheduled care. We also serve some undocumented individuals. One of our foundational beliefs is that access to healthcare should have nothing to do with citizenship status. Last year, we had 6,307 clinic visits, during which 1,589 patients received medical and/or dental care. This is slightly lower. These figures are slightly lower from the year before due to the pandemic and are having to change our service delivery. 98% of clinic users are uninsured or underinsured. The small percentage of people who do use our services who have insurance do so for reasons of confidentiality. In particular, they may come to the clinic for HIV counseling and testing or to receive STI screening. We are seeing increasing numbers of non-English speaking patients, in particular Spanish, French, and Arabic. We are seeing people who are presenting with more complex medical problems. And both of these factors, the language factors and the complexity of problems patients are presenting with, are leading to our appointments taking longer. 70% of our patients reported household incomes below the federal poverty level. 26% reported incomes between 100 and 200% of the federal poverty level. 80% were from Johnson County. 54% reported being employed. 51% of our patients in this last fiscal year reported their ethnicity as Hispanic or Latino. This figure goes up every year. We are serving more and more Spanish-speaking individuals, and we are always in need of Spanish interpreters. 67% of our patients identified as white, 22% as Black, 5% as multiracial, and 3% as Asian. 85% of patients we serve are between the ages of 18 and 65. There are other services available that assist people with healthcare costs who are under 18. There's a CHIP program, there's a Hawkeye program, and then there's Medicare for people 65 and over. But obviously populations of people fall between the cracks of these programs, and they are welcome to use our services. All of our patients face barriers to accessing needed care. All of them have financial struggles, which make paying for a visit to the doctor or a dentist impossible, not to mention the cost of medications, lab testing, and other procedures that they may need. Many may not have access to transportation. Many may not be able to come to an appointment and without losing their job. For our patients from other countries, language can be a barrier. And as I mentioned, we do the best we can to have interpreters available at every clinic to help patients feel welcome and to provide culturally competent care. We always try to hire bilingual staff. Cultural differences, obviously, can impact how patients receive care. For example, in some countries, people walk into clinics and wait until they are able to be seen. We are not a walk-in clinic, primarily because we use volunteers who can only stay during certain hours. Some patients from other countries may believe in a more spiritual cause of disease, or that a disease is due to an imbalance in a personal relationship. We all, staff and volunteers, always try their best to provide education in a culturally competent manner. Mental health challenges are perhaps one of the greatest barriers that our patients face. Our patients encounter. For many of our patients, healthcare problems, mental health problems can sometimes be seen as a curse or a reason to be shunned. Many of our patients, in particular refugees and immigrants, have experienced trauma and displacement from their native country, and we do not offer ongoing mental health care services at the clinic. We do our best to provide support when we can. We refer patients to a couple clinics that are available in Iowa City. A new clinic recently started through Iowa City Compassion that specifically targets refugees and immigrants. Medical students and medical faculty hold a free mental health clinic at the Abbey Center once a month or sometimes twice a month. We refer patients to both these options, but many more services are needed for non-English speaking people, and actually for English speaking people as well in our community. Many years ago, there was a community mental health center in Iowa City, which operated on a sliding scale based on income. And that kind of service is no longer offered in our community. So I think I'll stop there, Gail, and see if you have any other questions about our services.
So much to share. And like you were saying too, you know, this provides an option for individuals to go to that do not have health insurance, they're not eligible, or they simply cannot afford it, because you know the lower premium that you pay every month is really going to raise your copays, it's really going to raise your out-of-pockets. If you have a chronic condition and you're going to see your provider on a monthly basis, $25 can really add up over the course of the year. So one thing I do want to mention is that the free clinic, they don't take any kind of insurance whatsoever. It's basically offered for free, but of course, you know, patients can choose to donate what they can, but it doesn't take any kind of insurance. So it's kind of nice. You don't have that administrative burden of filing all of these insurance claims, because, you know, since I teach a course on the healthcare system, I know that it's extremely complex. A lot of people have really a difficult time navigating. So if it weren't for the free clinic, you know, what options would these individuals have? You know, you mentioned those vulnerable populations, those that maybe have lower health literacy, or are immigrants or refugees. And if they don't have a place to go, you know, what happens to their health if they don't have that access? I think that's, you know, what we're seeing is contributing to a lot of these health disparities, is because they simply cannot afford to go, so they simply don't go, and then things tend to get worse. So
yes, that's absolutely right, Gail. People who are uninsured.
We'll talk for hours about this, but
people who are uninsured, they simply have less access to recommended care, both preventative care and treatment for acute and chronic health conditions.
right.
When they do go to providers, the care they receive is of poorer quality, unfortunately. And as a result, they experience worse health outcomes than people with insurance. Some progress was made under the Affordable Care Act, but as I mentioned earlier, people of color remain disproportionately represented among the uninsured when compared to non-Hispanic whites. And as a result, people of color face higher rates of diabetes, obesity, stroke, heart disease, and cancer than non-Hispanic whites. People of color, unfortunately, are disproportionately represented among lower income levels, which just perpetuates the whole cycle of not being able to afford insurance, not being able to get treatment when you need it, and this leads to poor health outcomes. With diabetes, for example, the risk of being diagnosed is 77% higher for African Americans than it is for people who are non-Hispanic.
Yeah, so this isn't just a very minimal disparity. I mean,
no, it's a huge disparity.
Huge.
And in addition, being diagnosed with diabetes is 66% higher for African Americans than it is for non-Hispanic whites. Asian Americans, Native Hawaiians and Pacific Islanders are at 2 times the risk of developing diabetes than the population overall. So again, the disparities are not minor at all, the healthcare outcomes and the disparities. People who are uninsured, and again, these are people with low income, simply cannot afford the care that all of us deserve, preventative care and treatment for acute and chronic diseases. As a result, as we've talked about several times, they delay needed care for as long as possible, and this leads to poor health outcomes. It just goes on, and and people are, as a result, they get stuck in this cycle and they can't get out of it. And far too often, even today, people are blamed if they don't take care of themselves. And the reality is, our patients and people who are uninsured are amazing at finding ways to take care of themselves, at finding free clinics, at reaching out to nonprofits who will help them in whatever way they can. But they, like those of us who are fortunate enough to have insurance, should not have to struggle the way they do, should not have to work as hard as they do to get the health care they and their families need to thrive and to lead productive lives in the community.
So, in your opinion, and kind of conclude here, what do you think has to happen to reduce that gap? And I have a feeling I know what you're going to say, but I mean, what do you think has to happen?
I want to answer that question, Gail, but one more thing that I have to emphasize is that the health disparities is so demonstrated today in what's happening with the COVID-19 pandemic. You can see it right in front of you every day. The last I heard is that Latino and African American residents of the United States have been 3 times as likely to become infected with COVID than whites. And they have been nearly twice as likely to die from the virus as white people. So if anybody needs evidence of health disparities,
right,
you can see it right there.
We're seeing it right now.
As far as what we need to address the problem, we need to no longer have access to health care tied to employment. We need to no longer have access to health care tied to someone's income. Healthcare needs to be available to everyone in the community, regardless of their financial situation. Access to healthcare is a basic human right and a basic human necessity. And unless everyone has access to healthcare, the whole community's health is affected. It's a public health issue. And access to healthcare for everyone is simply a matter of the common good. It leads to healthier communities. Healthy communities lead to healthier conditions for everyone in our state and in our country. So we either need to have a public option or we need to have universal coverage of some kind. That's my answer.
That's your answer.
All I can tell you, Gail, is that what we have now is not working.
And you see that firsthand,
Yes, I do. We see that every day.
Every single day. Well, I just want to thank you so very much for taking your time out of your day. Your cat is in the background looking for I'm like, the door opened.
Yes, my cat likes to join me in my office.
Absolutely. One of the perks of working from home.
Yes.
Well, thank you so very much. And, I will also share some information with the students. Once hopefully things start returning a little bit more to your normal operations and start getting your volunteers. I'm sure we have some students who would love to learn a little bit more about the free medical clinic and possibly volunteer or, serve as an interpreter. So thank you for sharing so much about such a great organization.
Thank you, Gail.
Take care.